This project concerns research methodology of an investigation regarding medication errors and adverse drug events in primary care. The research question is, what are PCP's experiences with medication errors and adverse drug events in daily practice? This presentation will first cover some background information regarding medication errors and adverse drug events revealed in the literature review. It will cover why a qualitative framework is chosen, the steps that will be taken to promote rigor. We'll then explore the method of data analysis that will be used, and from there cover participant selection and concerns related to human subjects, and finally we'll close out with the limitations of the proposed design. The following definitions are prerequisite for understanding the research that will be conducted. A medication error is any preventable event that will cause or lead to inappropriate medication use or patient harm while the medication is in control of the healthcare professional, patient, or consumer. An adverse drug event, or ADE, is harm experienced by a patient as a result of exposure to a medication. And finally, primary care is care provided at the first contact point of the healthcare system and does not include specialist care. Not all MEs are ADEs, and not all ADEs are an ME. Medication misuse that doesn't result in harm would be just an ME. If a patient was to take a drug prescribed, take it correctly, and then develop an allergic reaction, that would be an adverse drug event, but not a medical error because it was not preventable because no one knew the patient had an allergy. Some ADEs are MEs, such as an unindicated antibiotic being prescribed to a patient and then they take it and develop a rash. The literature review revealed some background regarding MEs and ADEs. The rates of drug-related MEs, or preventable ADEs, as another terminology for it, is about 1 to 2% in primary care, and all ADEs is about 6 to 16% in primary care. However, these rates are closer to 20% of interactions among elderly patients. We know that polypharmacy and age are predictive factors for medication errors and adverse drug events, but we do not have good interventions to address this. The most used intervention is deprescribing, which is reviewing a medication list and removing medications from it and advising patients to no longer take those medications. However, the efficacy of this is questionable as it has not been shown to reduce hard outcomes such as deaths, falls, hospitalizations, or ED visits. The literature review also revealed discrepancy in high-risk medication classes between earlier research and more contemporary research. This may be because of changing drug formularies and changes in healthcare practice as a whole that have occurred over the previous decade. A qualitative design consisting on one-on-one interviews between the researcher and a primary care provider will be used to answer the study question. The merits of the qualitative design is that it focuses on process rather than outcomes. This is relevant because we know the outcomes of medical errors and ADEs. We know that they happen, but we don't know how they come about. Another feature of qualitative design is the theme of emergence, which dovetails with the theoretical framework used in Chapter 1 of complex adaptive systems. Emergence is also a principal theme in complex adaptive system theory. The indication for the qualitative design is to resolve the discrepancies in existing research mentioned in the previous slide and to lay the groundwork for future quantitative research that can hopefully change practice. The research will use Linka and Guba's trustworthiness criteria and elements from Paulo Hayashi's processual validity model to promote rigor and validity. The following steps will be taken to promote rigor and validity in this project. I'll pause for a moment while you read through. Credibility will be enhanced by prolonged observation, the employment of member checking and giving member participants the opportunity to elaborate on their responses and edit them, and reflexive journaling. Elaborating on prolonged observation, the project will allow re-engagement with participants, and as part of the processual validity model, Hayashi recommends that observation take place before research is ever being conducted and in the development of the research protocols. This will occur because the researcher will have completed 600 clinical hours with primary care providers prior to data gathering. Transferability is enhanced by having a clearly defined sample and research procedure, such as being discussed now. Confirmability is enhanced by the open-ended portions of the interview, and that the initial summary of themes will be shared with participants and they will be able to express their agreement, disagreement, or ambivalence towards the initially summarized themes. Dependability is enhanced through the closed-ended portion of the questionings and by keeping a record of how codes are kept. Miscellaneous quality enhancement strategies concern points 7 and 9, such as writing in the discussion the comparison between the results and the analysis of this project compared to projects addressing ADEs and MEs written in the existing research, and quasi-statistical tabulation of results. So answers that come up frequently between different participants will be tabulated for their frequency. This way, insights taken from those responses have some metric indicating that they are being expressed by multiple participants and not the researcher focusing in on just what one or two participants disclosed. The researcher will employ thematic analysis via Braun and Clark's 6-step framework. These 6 steps are familiarization with data, the generation of initial codes, a search for themes, reviewing themes, defining and naming themes, and finally writing the report. Important to note is that Braun and Clark's framework is recursive, meaning that the researcher will return to previous steps as he works through the project. The familiarization with the data will start with the researcher transcribing the interviews before subsequent rereads occur and before initial codes are generated. A record of the codes generated will be available to auditors, and papers will be coded by either highlighting transcripts in Microsoft Word or on hard copies as codes are tabulated and then themes are searched for. Then themes will eventually be reviewed to see that they agree with each other before being defined. And in the writing of the report, themes will be compared to existing research. Concerning inclusion criteria, participants must be working as a PCP for a minimum of 2 years in the current role and must be practicing in either Iowa, Minnesota, Nebraska, Wisconsin, or Illinois. Preference will be given to providers with greater experience, as they should have higher yield responses that will be more informative than a participant who has been practicing for less long. No preference will be given to whether a participant's a doctor, physician assistant, or nurse practitioner regarding their inclusion in the study, and the researcher will not reach out to his own preceptors as to avoid any sense of coercion. The study will employ volunteer sampling of Clark's list of family medicine preceptors, and then those participants will be encouraged to participate in snowball sampling so that the researcher can identify more high-yield participants. Snowballing is preferred over the volunteering sampling method, and interviews will continue until 15 participants and data saturation has been completed. Steps will be taken to protect human subjects. Firstly, the demographic questions have closed-ended answers and will be limited in scope. This is so that the answers to these questions cannot be tied to a specific person. On the side of the screen, you see what those demographic questions are and potential answers to them. The researcher does not wish to gather more detailed information than this as to avoid any anonymous participant being able to be identified just from the data they provided. The identities of the participants will only be available to the researcher and the auditor. The institution where the researcher practices will not be asked, nor will it be recorded. All interviews and data will be stored on password-protected devices. And participants are given the opportunity to withdraw or have responses removed at any time, and this will be made known to them in their consent form. The project has three principal limitations. One is the inclusion of open and closed-ended questions. Open-ended questions increase the confirmability at the cost of the dependability of the study. And the opposite is true as well. In effect, we are trying to optimize confirmability and dependability at the cost of not being able to maximize either. Additionally, while snowball sampling is superior to volunteer sampling, it could create a problematic scenario where a provider refers to other providers to be participants that all practice within the same institution, and the researcher could end up with a sample of many providers who are working at the same institution. This sample will not be generalizable to the wider healthcare system. Furthermore, if this happens, there's no way to disclose that all the providers are from the same institution without sacrificing the anonymity that is paramount to human design, or rather, research regarding humans. And then finally, qualitative framework and thematic analysis is a labor-intensive design. And with it being more labor-intensive and also more subjective than quantitative work, there's more opportunities for bias. Hopefully, reflexive journaling and the availability of auditors will reduce some of this bias, but it is still a limitation nonetheless. To summarize, our research question is, what are PCP's experiences with medication errors and adverse drug events in daily practice? The study's design will be qualitative in nature and employ thematic analysis to answer the question. Lincoln Guba's trustworthiness criteria and Paulo Hayashi's processual validity model will be used to promote rigor and validity. And the data will be gathered via open and closed-ended questioning and one-on-one interviews regarding MEs and ADEs. The following works were cited within this project. More references are available upon requests regarding the methodology paper. Thank you for your time, and feel free to reach out to me.